In this part, we will discuss electrocardiography, ECG or EKG. In the previous part, I discussed in details excitation of the heart. It produces electrical activity which can be recorded with ECG. A quick recap. Here we have in yellow the conduction system of the heart. It follows a very strict hierarchy. In the intact heart, the pacemaker, the primary pacemaker, is the SA node. It initiates the first electrical impulse. They travel down the conduction system of the heart, following a very strict hierarchy, seen here, which we discussed in previous parts. We have electrical activities, action potentials, and the electrical activity spreads from the heart to the skin, where we have different electrodes. And with ECG, we detect the electrical activity of the heart, which reaches the skin. Before we delve into the details, it will be very helpful to discuss some basics: resting member potential and depolarization. Let's assume we place a voltmeter outside of the cardiac muscle cells, so it can measure the voltage, whether it is present or not, and how strong it is, only outside of the cells. At rest, the inside of the cell is negative relative to the outside. So on the outside, we have positive charges, inside, negative charges. Because on the outside, we have only positive charges, no potential difference, no voltage, the voltmeter would not read anything. There will be no deflection. Strongly simplified. Now, when the depolarization starts, on one end we have negative charges, on the other end positive charges. The voltmeter placed outside of the cardiomyocyte will detect voltage, potential difference, because here we have minus and here we have plus. When the depolarization is complete, the outside of the cells has negative charges only, no voltage detectable with a voltmeter. This principle, please memorize. Let's take a look at recording electrical activity with a voltmeter. Here we have the negative electrode and here the positive electrode of the voltmeter. Now we connect the charge battery to the voltmeter. The negative potential of the battery is connected to the negative electrode. The positive potential of the battery connected to the positive electrode. So then we will have a deflection and it will also be positive because positive to positive, negative to negative. Now we flip the position of the battery. Then we have a negative deflection. What if we take this example? Now in this case, we increase the voltage of the battery, indicated here by the larger battery. Again, it will be a positive deflection and the signal will be much stronger because the voltage has increased. If the battery is empty, no voltage, no signal, no deflection. Now, let's take the analogy to cardiac muscle cells. Here we have the voltmeter placed outside of the cell, so it detects the activity only on the outside, whether there is a voltage or none, and how strong is the voltage. In resting state, outside the cells, we have only positive charges. There will be no deflection, no voltage. Now we have depolarization in progress. On one end, negative charges, on the other, positive charges. The negative electrode of the voltmeter is facing the negative charges, the positive electrode facing the positive charges. So there will be a deflection and it will be positive. Depolarization complete. Here we see negative charges outside the cell. There's no potential difference, no voltage, no deflection. Now please remember the following rule. This will be very helpful to understand the deflections in the ECG recording. Depolarization wave. If it moves from the minus electrode to the plus electrode, it will give us an upward deflection. If it moves from the plus electrode to the minus electrode, it will give us a downward deflection. And the opposite is true for repolarization. Let's take a look. Here we have the negative electrode, and here's the positive electrode. We start the depolarization wave from minus to plus, hence positive deflection. In this case, full depolarization, there is no potential difference, no voltage detectable. Flat line, zero potential, isoelectric line. Now we start the repolarization. Normally, the place which depolarizes first, is also the place that repolarizes first. So now we have a repolarization wave going from the minus electrode to the plus electrode. According to this rule, it will give us the negative deflection. Please remember this rule, it will be very helpful. Depolarization waves advance through millions of cells in the heart. Remember, we have gap junctions between the cells. I would like to stress that what we measure with ECG are in fact dipole moments expressed as vectors. However, this would go way beyond the scope of this part, so I will not discuss the details. I'm mentioning this just for the sake of accuracy. So just to quickly give you an idea, what are dipoles, electrical dipoles, and dipole moments and vectors? Here we have a minus charge, and here's a plus charge, separated by a distance d. An electric dipole is a pair of equal positive and negative charges, seen here, q minus q plus. If they are separated by a distance d, this becomes a dipole moment. And this advances through millions of cells in the cardiac muscle. What else we need to know? The depolarization dipole has a vectorial expression, so the dipole moment can be expressed as a vector. It goes from minus to plus, so this vector has a direction. It also has a magnitude, and to simplify, really strongly simplify, the magnitude is in a way, as far as ECG recording is concerned, the larger the number of cells to be excited and the larger the muscle, the larger will be the magnitude of the ECG recording. So this is strongly simplified. The electrical activity that stems from the heart reaches the skin. It becomes weaker on the skin, but it will be amplified using the ECG system. Here we see the example. The mass of the ventricle is much larger than the mass of the atria. The vectors in the ventricles will be stronger in the ECG recording. So now, let's move on to ECG recording step by step. The reason why we are able to detect the electrical activity stemming from the heart when it reaches the skin is because our body is a good conductor of electricity, as we see here in this animation. So we place the electrodes, the ECG electrodes, on the skin. They amplify the electrical activity that reaches the skin, so we can see here the ECG recording. The details will follow. Now, the heart, the electrical activity in the heart spreads in many different directions. 1 voltmeter won't be enough to detect the electrical activity at high resolution. Let's assume we have just 1 voltmeter placed this way. Here's minus and here's plus. This position of this voltmeter detects best the electrical activity running horizontally. Seen here again. However, what if the electrical activity were not running horizontally but angled? The deflection will be weaker, as we see compared to this signal. And in fact, if the electrical activity is running perpendicular, then there will be no deflection. So, what is actually the solution for us in order to record the electrical activity of the heart with high resolution? Well, we place different voltmeters in different positions. Here, strongly simplified. This voltmeter, placed here, will detect best the electrical activity running this way. This voltmeter, placed this way, will detect best the electrical activity running this way. So we see here, in this schematic, we can place several voltmeters in different positions. This enables us to detect the electrical activity of the heart at high resolution, as we will see later. So here we have the two-dimensional way of detecting the electrical activity. However, the electrical activity of the heart is running in a three-dimensional way. So here we have the anatomical planes of the heart, and we would like to look at the electrical activity of the heart from different angles, from different anatomical planes. And this is indeed possible, as we will see later on. Here's an overview of the 12 leads and how they are placed on the body, on the skin. Before we delve into the details, I will just summarize for the overview the following. We use 6 limb leads, also known as frontal leads, and 6 chest leads, also known as horizontal leads. The frontal leads are Einthoven's 1, 2, and 3 leads. We can see how they are positioned. Lead 1, lead 2, and lead 3. And according to Goldberger's leads, AVR, AVL, and AVF. These 6 leads are the limb leads, the frontal leads. They are looking at the electrical activity of the heart from frontal positions. Here we have the heart in a circle, and the cameras represent the point of view of the electrical activity of the heart. So how we are looking at the electrical activity of the heart. Okay? For instance, this camera is looking at the electrical activity of the heart in lead 1 from this position. And this camera is looking at the electrical activity from lead 2, and this from lead 3. Here AVF, AVR, and AVL. But more details will follow. We can also add horizontal leads. So then we have here 6 frontal leads looking at the electrical activity of the heart from frontal perspectives, as we see here in the circle, and 6 chest leads looking at the electrical activity from horizontal perspectives, V1 to 6. The details will follow. Now we start to discuss the details. We start with leads 1, 2, and 3 according to Einthoven. Lead 1, the negative electrode is placed on the right arm, the positive on the plus arm, the positive electrode on the left arm. In lead 2, the negative electrode on the right arm, the plus electrode on the left foot. In lead 3, the negative electrode on the left arm, the positive electrode on the left foot. So now, if we put the heart in the middle of this circle, we have lead 1 indicated by the blue arrow. It's going from here to here horizontally. The angle is 0. Lead 2, the green arrow, the angle is 60 degrees. Lead 3, 120 degrees, you can see here. So here we see the symbols of the eye. This is the position from which we're looking at the electrical activity of the heart. So now we have leads 3, 2, and 1 placed in this circle. They are about 60 degrees apart from each other. We can improve the resolution by adding more leads, as we will see later. And here I'm referring to the so-called Goldberger leads, AVR, AVL, and AVF. I'll discuss the details later. But before we discuss Goldberger's leads, let's discuss the details of the Einthoven's leads, 1, 2, and 3. Lead 1, lead 2, and lead 3. If we put them together, we can create a so-called Einthoven's triangle. This is the Einthoven's triangle, lead 1, lead 2, and lead 3. Simplified, we can say, in the middle of the Einthoven's triangle, we've got the heart. The electrical activity of the heart placed right in the center of this triangle, Einthoven's triangle. So we can look at the electrical activity of the heart in leads 1, 2, and 3 from different angles. In lead 1, we're looking from this angle. In lead 2, we're looking from this angle. In lead 3, we're looking from this angle. Remember, these 3 leads are 60 degrees apart. This is not bad, but we can still increase the resolution by placing more leads between the different leads. And this is what we need Goldberger leads for. So here again, we see again, lead 1, lead 2, and lead 3, according to Einthoven, separated by 60 degrees. We can shorten the distance between the leads to 30 degrees by using Goldberger's leads, indicated by the blue asterisk, AVL, AVR and AVF. I'll discuss the details in the next slides, what AVR, AVL, and AVF stand for. So here we have lead 1, 2, and 3. The idea behind Goldberger's leads is the following. The exploring electrode, that is the plus electrode, is compared with a reference which is based on an average of the other two limb electrodes. So here is AVR. A stands always for augmented V voltage on R right arm. This lead, AVR, we have here the average of the two limb blades, left arm and left foot. The reference electrode is here, the green asterisk. This is the negative electrode, the average of these two limb blades compared to the right arm electrode, which is the exploring electrode, the positive electrode. AVL, again, A augmented, V voltage, L left arm. Reference electrode in this case is the average of these two limb blades, right arm and left foot, compared to the exploring electrode, which is placed here on the left arm. Here we have AVF, F for foot. The reference electrode is the average of these two limb blades, right arm, left arm, compared to the left foot electrode, exploring electrode. So now we have these 6 leads. Let's take a look what they create. Lead 1, lead 2, lead 3, then AVR, AVL, AVF, and here we go. So they are separated by 30 degrees. So now we have increased the resolution significantly. We are looking at the activity, electrical activity of the heart, frontally from 6 different perspectives. Lead 1, lead 2, lead 3, and then AVR, AVL, and AVF. Now we will discuss the chest leads. We have in the chest leads the following. A reference electrode, which is also known as Wilson Central Terminal, WCT, right here. What is it actually? Remember, this is the Einthoven triangle, and the heart is in the middle of the triangle. In the chest lead system, we have the WCT, Wilson Central Terminal, which is a theoretical reference point in the middle of this triangle. It is computed by connecting all 3 limb electrodes. In order to do so, we connect them with a very high resistance. So it is computed by connecting all 3 limb leads to one terminal. This terminal represents the average of the electrical potentials recorded in the 3 limb lead electrodes. So this would be the average of the 3 limb leads. This would be the reference electrode, if you will, compared to 6 positive electrodes, V1, V2, V3, 4, 5, 6. The advantage is actually huge. They enable us to look at the cardiac activity horizontally. And we can also say, and I will discuss the details in a separate video, V1 and V2 are looking at the electrical activity of the heart more concerning the septal regions of the heart. V3 and 4, the anterior regions of the heart. And V5 and 6, the lateral regions of the heart. Here we see, using different cameras, the way we're looking at the cardiac activity, frontal leads. And then we can, if we combine the 6 limb leads with the 6 chest leads, we can discover various pathologies, if available. I will discuss pathologies in separate videos. Just to give you an idea, here we've got the heart, 3-dimensional, the different anatomical planes. We have the coronary arteries, right coronary artery, circumflex, left anterior descending artery, and using all 12 leads, we can separate the electrical activities, I mean the way we're looking at the electrical activities. To simplify, leads 2, 3, and AVF are looking at the inferior activity region of the heart. V1 and 2, septal activity. V3 and 4, anterior. V5 and 6, lateral. And 1 and AVL also lateral, though from a different angle. I will discuss different pathologies in a different video. I would also like to stress that we also use grouping in ECG recording, but this too I'll discuss in a separate video. Before we delve into ECG tracing, a quick recap: the cardiac conduction system. Remember, the primary pacemaker, the SA node, triggers the first signal, travels down the conduction system, and here we have the cardiac skeleton, which is an electrical insulator, which we discussed previously. We need it. Why? Because here, when we excite the atria, they need some time for their excitation and contraction. We would like to have the contraction of the atria first, and only then should the ventricles also be excited and contract. So for this, we need an electrical insulation between the atria and the ventricles. This is why we have the electrical insulator. Then we also discussed the AV node in the previous videos. It slows down the conduction velocity, and this was of substantial importance. Why? Remember, first we would like to excite the atria. They need some time for their contraction, as we see in this beautiful animation with this source. We excite the atria, they need some time for their contraction, and only then should the signal be passed down the conduction system of the heart until it reaches the ventricles, so then they will also contract. I discussed the numbers in previous videos. The SA node, when it fires the first signal, it reaches the AV node within 30 milliseconds already. However, full excitation and contraction of the atria needs much longer, as we see here indicated by the number. So we see the AV node slows down the conduction velocity. So now we have an overview of the ECG tracing based on lead 2 according to Einthoven. We have a P wave, QRS complex, and T wave. We will discuss the details step by step. And these arrows indicate the vectors, the depolarization or repolarization waves, which we will discuss in the next slides. Before, a quick recap. Always remember this rule: depolarization and repolarization waves. This rule is very helpful to understand, always, to memorize. Depolarization wave from minus electrode to plus electrode, upward deflection. Depolarization wave from plus electrode to minus electrode, negative deflection. And the opposite is true for repolarization. So now we have lead 2 according to Einthoven. Remember, in lead 2, the minus electrode, the negative electrode is here, plus electrode is here. SA node triggers the first signal. You would expect a deflection. This would be logical to assume. However, the mass of the SA node is so small, the number of cells is so small relatively, so it produces no signal. The signal is so weak. We see no voltage reading in ECG. So the flat line just before the beginning of the P wave, which is the excitation of the atria, this flat line before the excitation of the atria, this is the excitation of the SA node. Again, too small mass, too weak a signal, it cannot produce a signal at all, flat line, no voltage detectable. Now we start the depolarization of the atria, which is signified by the P wave. Now we have depolarization wave going from the minus to plus electrode, so it should give a positive deflection. Indeed, the P wave is positive. Depolarization wave from the negative electrode to the positive electrode, positive deflection. At this point in time, remember, the signal has already arrived at the AV node, indicated by this arrow. Here I've got some numbers that are very helpful to understand, but I'll discuss them with different pathologies in a separate video. The P wave takes less than 0.12 seconds. Now comes the brief isoelectric line or zero potential after the P wave. Here. At this point, the atria are fully excited. No voltage detectable. At this point, we have reached already the AV bundle, the AV node, then down the conduction system of the heart, we reach the His bundle, and then left and right bundle branches, and then Purkinje fibers. We're talking about these regions. These non-contractile cells of the conduction system of the heart like the SA node, produce no signal. Too little mass, too few cells, they produce no signal, hence the flat line. We also have the so-called PR interval. What does it stand for? Here we start the excitation of the atria. At this point, they are fully excited, this line here. PR interval describes the following. It represents the time between the onset of atrial depolarization, which is here, and the onset of ventricular depolarization, which starts right here. I will discuss in the next slide. Okay? And normally it takes about, this PR interval takes about 0.12 to 0.2 seconds. If it is prolonged, this may be an indication for pathologies, which I will discuss in a separate video. Normally, if this is a light prolongation, is may be an indication for conduction block, AV conduction block. Now we start the depolarization of the ventricles, which is also known as the QRS complex. Here we see the vector, the brown. The depolarization wave indicated by this vector is showing from left to right, from the plus electrode to the negative electrode. The beginning of the excitation of the ventricle starts from the left ventricle and proceeds to the right. Why? There are many reasons. The major reason is that the Purkinje fibers in the left ventricle are much more pronounced compared to the right ventricle. And the left ventricle mass is also much larger than the right ventricle. So we start at the septum in the ventricles from left to right. The depolarization wave indicated by this brown arrow is moving from the positive electrode to the negative electrode. This will give us a negative deflection known as the Q wave. Okay? So we start the depolarization of the ventricles from left ventricle to right ventricle, from the plus electrode to the minus electrode, hence the negative deflection. Now we have this vector here, this depolarization wave. This vector is the strongest by far. Why? It represents the largest parts of the ventricles that are being almost instantaneously depolarized. So we here see the depolarization wave spreading from here all the way down. Many millions of cells in the ventricles, and this vector in blue represents the depolarization wave direction from the minus electrode to the plus electrode, hence positive deflection, and many cells, large mass, hence a strong deflection. This is the so-called R wave. Okay? Then we have the last regions of the ventricles to depolarize from here to here. And the depolarization wave is indicated by this red vector. We can see by the red arrow. It's going from this direction to this direction, basically from the plus electrode to the minus electrode. This means depolarization wave from positive electrode to negative electrode, negative deflection. This is the S wave, a small deflection because we have here very few cells compared to the mass which we have right here on the left ventricle. So now we have reached a state where the ventricles are fully depolarized, fully excited, indicated by the negative charges everywhere. And this is the flat line. Ventricles are fully depolarized. No voltage, because full depolarization, remember, gives no signal. This area is also known as ST segment, and it might be elevated or depressed, and this stands for pathologies, which I will also discuss in a separate video. Again, remember this rule, golden rule. Depolarization wave from minus to plus electrode, upward deflection. Depolarization wave from plus to minus, downward deflection. And the opposite is true for repolarization. Now, why is the T wave positive? Remember, the depolarization starts from the endocardium, spreads out to the epicardium. So the endocardium is first to depolarize, the epicardium is last to depolarize. However, the repolarization is such that the epicardium, although it was depolarized last, it is first to repolarize. The reasons will be discussed in the next slides. So for now, please remember the following. We have here a repolarization wave, and the vector of this repolarization is showing from here to here. So this is a repolarization wave going from the plus electrode to the minus electrode. According to this rule, this will give us a positive deflection. This is why the T wave is positive. A repolarization starts from the epicardium and moves down to the endocardium. A repolarization wave from the plus electrode to the minus electrode will give us an upward deflection. Okay? So, why is the repolarization starting from the epicardium? I'll discuss some reasons. The major reason is the following. During contraction of the ventricles, the blood vessels in the endocardium are strongly compressed. So, not enough oxygen is reaching them, so the action potentials in the endocardium take longer than the action potentials in the epicardium. We see in this animation the compression of the endocardium much stronger than the epicardium. Here we take a look at the action potentials in the endocardium here and epicardium here. The endocardium, the action potential is longer than the action potential in the epicardium. So even though the endocardium starts the depolarization and takes it all the way to the epicardium, while the epicardium is starting to repolarize, you see, the endocardium is still excited. This is why the repolarization moves from the epicardium to the endocardium, indicated by the arrow. So to summarize, these are the vectors. The depolarization wave in black here stands for the P wave. Vector 2, the brown, this is the depolarization wave for the Q wave. The blue vector, depolarization wave, R wave. Vector 4, this is the last region of the ventricles to depolarize, S wave. Vector 5, the green, the T wave, repolarization vector. I hope this was helpful.